guys have, and we'll go from there.
Well, I just wanted to thank you for your advice last time.
Yes, you were going to go visit your family, right?
We did, and we gave us the confidence to do that in Idaho, and it was wonderful. So thank you.
Great, good. I'm glad to hear it.
It went very well. Yeah.
I'm glad, and I think that you'll see that, or you'll have noticed that the public health guidelines did actually kind of change over time to kind of be consistent with that. And I think that's, the CDC's been pretty careful over time to not move ahead of what they feel like the data is. And so I think like the advice that we talked about last time was pretty sound from the science, and it just took the federal government a little bit longer to kind of come around to actually provide that guidance on a broad scale. So I'm glad that that worked out in a way that you felt like you could, actually celebrate with your family.
And it was funny because the pilots would get on and say, okay, if you're having a snack, eat it quickly. You can't eat a bag of chips for the whole flight. Eat it quickly, then put your mask back on. So they were very serious about masks on the airplane, and everybody wore them. So not always not at the airport, but but on the airplane, they were very good. Yeah.
Really, the airport is the concern. I think I said that last time too. Like the airplane, you're in pretty safe hands with the air exchanges and again the strict masking. But yeah, the airport is where I really try. I've been now. I was actually just a few weeks ago. I took a one-way trip to Chicago for an event, and so yeah, I'm like really try to stay. Even being vaccinated, try to stay away from everybody and go sit in a separate gate. And yeah,
that's what we do. Yeah. Well, thank you.
Absolutely.
Jean, did you have a question?
Yeah, I'd like to hear him speak about the variants and how worried we should be about the variants if we're fully vaccinated.
Yeah, great question. So the variants, I appreciate they call them variants. I think we've done a good job now. Finally, the messaging's gone out. It's not like mutants or mutations, it's variants of concern. And because mutations are rampant, constant, and to be expected. So these are specific mutations or groups of mutations in certain circumstances that lead to what ends up being kind of a change in the viral makeup that leads to an actual change in the way that the virus behaves. So its infectivity, its ability to cause disease. And so that's why these are called, we call them variants of concern, specifically VOCs. And so there are a number that you've probably heard of. And the first thing I'll say, I'll try not, I will here kind of refer to them in their common parlance, which is by geographical location. I think as a scientific community, we're trying to get away from using the geographic notations just because they can be stigmatizing. And I know that can feel a little bit like, that can feel a little bit PC, but it's absolutely true that, a lot of times these variants do not originate in the places where they're identified. And it's really the places where they're identified that end up getting associated with them. And they find them because they're actually usually doing the right thing, which is doing lots of surveillance in order to identify these variants. So in any case, the ones that are specifically for vaccination, the ones that are most concerning to scientists are the South Africa variant, which is 329, and the Brazil variant, P1. So those are the two that are able with some degree to kind of evade more of the immune response that's created by vaccines. They decrease the ability of those vaccines to have as high an efficacy rate with respect to mild disease. And we talked about this before on our previous discussion about how even though there are differences in the different vaccinations with respect to the percentage of efficacy or effectiveness related to mild disease, they all are incredibly effective against preventing severe disease, hospitalization, and death. And so what they've found so far with the variants is that even for P1 and for the South Africa 329, that these variants still provide good efficacy against hospitalization, severe disease, and death. So it's for vaccination, they're still monitoring those because those are the ones that cause the biggest decreases in efficacy against mild to moderate disease. And so they can go down, I mean, especially with the P1 Brazil variant, they can decrease efficacy a significant amount down to like, 20%. And we can talk about that. I'll talk about that in a minute, but those are the most concerning two variants. Luckily for us, they're also probably the lowest variants in terms of percentage penetration that we're seeing on US surveillance studies. So the most common ones that we're going to see are B117, which is the UK variant. That's by far has the highest penetrance in the US, and as you probably heard, is now, in terms of single variants, has overtaken the original SARS-CoV-2 viral genome as the most common individual variant that they are isolating now from specimens across the United States. So the B117 is the most prevalent, and then you've got what they call the California variant, 429, and then the New York variant, which I honestly can't remember the number for, it's E something. And so those are more common in US cohorts when they're looking at the number of variants that you see in the population, but they're not really significant in terms of degrading immune response to vaccines. And so you'll see, I mean, I was going to allude to the P1 variant in Brazil. I mean, you'll probably have noted, or you may have heard that Brazil, and we could talk a little bit about, Brazil's situation with respect to COVID, but it's really horrible. They've really had almost no systematic national response to COVID, and their vaccination rates have been very low, and they were kind of, hoping for herd immunity to cause to really benefit them. And they really did have, especially in a couple of cities, one in particular that's been well studied in Manaus, which is actually in the central Amazon. So it's very isolated from a lot of other things. They had a prevalence rate of having had disease in the 60 to 70% range. So what, in some situations you might expect to deliver herd immunity with the original variant. And then when the P1 variant came in again here in the last month or two and has now spread throughout the country. But that whole community again experienced a really severe outbreak that led to innumerable hospitalizations and deaths. And so that's what can be seen. And that's why vaccination is really the only way we have ever achieved herd immunity, and probably will, because these are the sorts of things that can happen when you don't have the robustness that a vaccine immune response can elicit. And so, so now in Brazil, we're seeing 4,000 deaths per day. I mean, it's really the most severe, horrible spot in the world for COVID deaths. So that's that. And the other thing I wanted to say, I guess, related to that is that then you'll hear that it's a little bit different in terms of monoclonal antibody response. So that's something that we could talk about separately if you're interested. But the monoclonal antibody response to some of these variants is lower. So that's a treatment that we use for patients who are at high risk of disease, especially those who haven't been vaccinated or have had incomplete vaccination. And we give it to them in order to prevent them going into the hospital. And so these variants, many of them, not just the P1 and the B329, but many of the variants, including the ones here in the US from California and New York, can cause decreased efficacy in those monoclonal antibodies. And so in order to kind of maybe tie that in for you, so these monoclonal antibodies are just one or two antibody products that are then used to help give the person passive immunity. So you kind of give them a B cell immune antibody response, and then that can tamp down the infection, prevent severe disease. The reason that your immune system works so much better, and like I said, it's able to keep you from, prevent people from having hospitalization and death with the vaccine response, is because you have to understand that when you have a vaccine response, you're triggering a lot of antibody production. So many antibodies, so not just one or two, but 4, 5, 6, and then your second and third, sometimes multiple vaccinations later. Each time you get a vaccination, your body sort of is like, well, I don't have to produce that antibody this time. And it spends time working on additional antibodies. So it builds out the number of antibodies that it can produce. So by the time you've had 1 and 2 vaccinations, this is why getting multiple vaccinations is a thing that we do commonly. is because it broadens the number of B cell antibody response you can create. And then it's not really talked about very often, but don't forget that there's also another big part of our humoral antibody response, which is the T cell response. And these vaccinations also elicit a strong T cell response. And so that is another way in which vaccines produce immunity to disease. And so when we give these like 1 or 2 monoclonal antibodies, a little bit of variation in the virus can cause a big problem for 1 or 2 antibodies. But when you give someone multiple vaccines, you have a lot of a B cell response, you have a T cell response. So it's very difficult for 1 or 2 variants changes in the virus to evade all of these different mechanisms. So that's why vaccination leads to a much more robust response. That was probably way more complete than you were looking for, but I think there's a few important kind of concepts there to kind of tie together that you're going to hear in the the discussions in the literature lately. So any follow-ups there, Jean?
Thank you, Brian.
Yeah, of course. Who else has a question? In the chat, Nancy asks, how long does the vaccine last? Well, that is the question, and we still don't know. I think I said last time we don't really know yet. And I said at the time that I thought that it was likely that the vaccination response, based on what we'd seen in clinical studies to this point, was going to last over a year, maybe 2 years was kind of like my best guess. And really the best, honestly, to tell you, not my best guess, but the best guess of virologists who actually really know, who look at immune responses and then have studied what actually happens in real life years later. So the people that I read kind of have guessed that it was probably going to be a multi-year efficacy, that the response would last and wouldn't require another booster for some time. So I don't have any change in the prediction about that. I think that we still believe that that's probably going to be true. And again, I said it the last time, the reason that I think it's still possible that some of us may, or all of us may get recommended for another vaccination at some point this year or next year would simply be due to variants, as we just discussed. So because there's concern, and specifically they've already started developing a vaccine, at least for the mRNA vaccines, they've already started, the Moderna and Pfizer groups have already started working on booster vaccinations specifically targeted against that South African variant, because it's one of the ones that leads to more of a decrease in vaccine efficacy. So I don't think that we're going to need to be revaccinated in the near term for the original SARS-CoV-2 sequence. But I think that it is possible that at the very least, they're going to recommend that for high-risk individuals, people who work in healthcare, people who work in frontline professions, that they probably get a booster vaccine once those are available. My guess it's going to be early next year or sometime next year. So that's sort of, I think, the latest probably on vaccine persistence. But yeah, we're really not going to know until we know, until it's been a year or two and we see sort of, are people who got vaccinated originally coming in with, ending up hospitalized with more severe disease. But those are the best guesses. Go ahead, please, Marilyn.
Could they combine it with the annual flu shot and put it all together in one big whammo?
It's possible down the line. The thing is, they'll have to study them together, and the FDA won't allow them to kind of combine them into a single shot without kind of studying them that way. But there's the difficulty is that currently the way in which these vaccines are produced are quite different. So usually when they combine vaccines, they do so of vaccines that are of a similar type and that use similar adjuvants, and the way they're created is similar. And so at least for the ones that we're getting, the Moderna and Pfizer mRNA vaccines, that's a new vaccine technology. It requires very specific type of vaccine packaging. So it's kind of packaged in a little fat liposome. It's like a little fat sphere. and it requires a little bit more special handling than do some of the other vaccines. And so it's probably going to be harder to combine that with the typical flu vaccine, which is much better. It's easier to store, and it's created through a whole different technology, which means kind of the stabilizations, the things that stabilize the formulation of the particular vaccine are different. So not saying it can't be done, but they're probably not even going to begin working on that for a period of time, as they're still just trying to get the original vaccine out and working on variant boosters. So is it possible though? Sure, absolutely possible. And I'm sure it'll be something that people work on if it becomes more necessary that we get regular vaccination, right? Like they won't, if it's something that we only have to get, like a pneumonia shot where you get it, 3-4 times as a kid, and then you get it once as an adult and once as a senior, then, there's no reason to formulate it with something you need to get every year. But yeah, as time goes on, they'll absolutely investigate those things.
What about the contention that these mRNA, this mRNA technology is actually gene therapy, and it may affect down the road what life insurance covers if someone passes away? That's a rumor that I've heard within the past couple of weeks. Do you have any information about that?
Yeah, there's not really any concern that these mRNA vaccines can lead to persistence of that viral message, or that, antisense anyway. The message that the mRNA encodes for can be incorporated into your genetic code. It's just not possible. There's only one type of virus that can do that, and those are retroviruses like HIV. And they have a very special protein that enables that to occur. And people do not have that. That's a not natural protein that any of us would have. It's not something that we put in the vaccines. And mRNA in and of itself is very unstable. So that's why they have to package it in this kind of fat sphere, because otherwise, if you just had the naked mRNA, it wouldn't even make it from the factory to your arm without being degraded. It degrades in minutes in unstable circumstances. And so in order to have that mRNA be able to be functional and be able to be read in the lymph node, the nearest wherever the vaccination is given, they have to do a lot of special formulation that's taken a long time, honestly, technologically, to be able to develop and perfect. And so there's really no way that mRNA that's given to you persists beyond literally hours after those spheres break down. It's in the place where it needs to be, and it gets read, or at least a significant amount of it is, and then it is eliminated by the body almost immediately. It's broken down. And you don't have the proteins either in you or in the vaccine, or honestly, really in any way, to be able to turn that mRNA into DNA, which would be required for it to end up being incorporated into your body in any meaningful way with persistence. So yeah, so I would definitely chalk that up as a rumor. It's not really, there's no way for it to be persistent, and it's not like gene therapy in that sense, in which case that sort of is the idea of gene therapy, to incorporate genes into your genetic code in some way in order to kind of be able to persistently produce a protein that's needed to treat a particular infection. So yeah, it does not work in that way.
Okay, that's kind of what I thought, but you've got acquaintances and friends and so on that say this is mumbo jumbo, it's gene therapy, and of course you still have the people saying that they're putting little chips in the I'm like, how is that happening? So but thank you, I appreciate that.
Yeah, absolutely. Yeah, there's definitely real scientific reasons why that's not the case.
I think Nancy had another question in the chat.
Oh yeah, that's right. She was asking, I saw about kids and teenagers. Let's see. Yep. yeah, interacting with them. And so I guess we can talk about, yeah, interacting both as like a vaccinated or an unvaccinated person, I guess, but they're sort of, I mean, not too much different, I would say. So yeah, so there's a lot of concern over, you know, as especially again, the B.1.1.7 variant, as it's become more penetrant in the community, and it leads to its main characteristic in terms of what it does is causes a significant increase in the amount of virological spreading. It can spread much faster and easier, even if it doesn't necessarily cause much worse disease. So because of that, we've seen a decrease, especially so vaccinations have gone up, especially in the older populations and the at-risk populations. And this variant has come in to make the virus more transmissible. We've seen a decrease in the average age of patients that are being diagnosed as positive with COVID. And that has led also to a significant increase in the number of people under the age of 18 that have developed symptomatic disease, because they're just getting larger volumes of virus, larger numbers of viruses around them when they are infected, because of that B.1.1.7 ability to be more transmissible and replicate more with more fitness. So so that's kind of the scientific reason there. I mean, as one example, here in Omaha, just 2 weeks ago, there was an outbreak at a daycare center they've been working through the pandemic. They have basically like gold standard approaches to all the things you would want to do. It's a well-to-do modern daycare center. They have good ventilation. They did all the things that you're supposed to do. And they've been, aside from a month or so when everything happened in April, May, they shut down. They've been working, otherwise since then to take care of kids. And they've had, I think, 1 or 2 isolated cases, here or there for the whole, 9 months. And then a couple of weeks ago, they had 100 associated cases that started in that daycare center, between kids, workers, and then people in those families associated. 100 cases that developed, all associated with the B.1.1.7 variant. So yeah, so is it a concern? Yes, from a transmissibility perspective, and we're just going to see more and more kids and young people until we can get vaccination up. Again, remembering that B.1.1.7 is not a problem for vaccinated people. It really doesn't have any doesn't decrease the efficacy of the virus in any meaningful way. It's just if you don't have if you haven't been vaccinated, it is just going to be much more transmissible among the unvaccinated. So how do we handle that? So I think what you do is that you have to be careful around your children as long as there's still this amount of virus circulating in the community. So it's not a concern for vaccinated people spreading it to kids. The data continues to come out. We talked a little bit last time about how vaccinated people have probably a 70 to 90% decrease in the chance that you could spread virus to others. The chance that you could even get infected and carry virus is lower by 70 to 90%. And then spreading it is so much harder because the amount of virus you would have is so much lower. The chance you would spread it through casual contact is very low. So if you're doing what you would normally do in public, around people who are unvaccinated, to just wear your mask, try not to get infected yourself, and then try not to spread it. I think you're doing the right thing. The question, so like for me, so my wife and I are both vaccinated. We have 2 elementary school age children. So what does that mean? Well, for me, I can talk practically about, we still avoid taking our kids out in public situations when we can, because we know that there's still a risk for them to get infected. We'll go now. So like we went out to the, botanical gardens yesterday, and we'll still do things that are on the lower risk scale. But, my daughter is really getting into college volleyball, and we're having the big college volleyball tournament here in Omaha starting next week. And she wants to go really badly. I'm like, I don't think we should go. Sorry, I don't think that's going to be something that's on our list. We'll watch it on TV every night. So we're trying to still avoid, the kids go to school here, that's, in my opinion, necessary. We try to limit our kids' exposure to only things that are necessary or to low risk situations. That being said, the last thing I kind of want to say about kids especially is, and I can't remember if we've talked about this before, but there's clearly a divide between once you get to about 13 years old, 12, 13, they become more like adults in their ability to kind of transmit disease, and when they are infected, to develop symptoms, at least in terms of from about 12, to about like 40, 50, we have kind of similar, relatively low rates of people, once you get infected, to actually develop kind of more severe disease or to develop long COVID, which we could talk about separately. Below the age of 12, the rates of people actually getting, quite sick and going into the hospital are very low. And it's actually interesting to note that it's actually probably about half or 70%, somewhere lower than you would expect with the seasonal flu. So with kids, so we normally think with the seasonal flu, it's the very young and the very old that bear the burden of morbidity and mortality. And so if you think about, okay, how do we normally behave in the wintertime with our kids? And our worry about flu causing, severe disease, it's different. It's actually much less in terms of COVID. If they were to get COVID at my kid's age, going on to develop a severe infection is actually quite low, much lower even than flu. So, does that mean I should be, super concerned that they're going to get, severe disease, end up in the hospital or die? No. But at the same time, they can still spread the disease, they could still have, get some measure of infection. So I think that there's reason to kind of, be reasonable and not be overtly scared that, okay, if my 5-year-old or 6-year-old gets sick, that they're going to end up in the hospital at a high rate. No, generally not, but they can still contribute to spreading it to many other people. And certainly they can develop, some rate of complication. So I think in the medium term, what we have hoped to do was, once the community rates of disease got down to a very low level due to infection, due to immunity, we were hoping then to be able to sort of do some more of these things with the kids. They're going to be protected, hopefully, by the low rates of transmission in the community, even if they're not vaccinated, and they're not, my kids' age, are not likely to get vaccinated till at least probably the winter time would be my guess. And so, we were just kind of waiting for that to happen. Well, now it's a little bit more in flux, as, again, we said vaccination rates are going up as variants come in. That's kind of meaning that for the moment, the rates of infection in the communities are at least plateauing, kind of close to where you guys are, and you've heard, I'm sure, in places like New Jersey, Florida, Michigan, the rates are actually going up because they're having outbreaks that are kind of actually overcoming the ability of the population to get vaccinated quickly. So, I'm very optimistic that over time, assuming that vaccination rates continue, we were over 4 million vaccinations yesterday, which is a new high. As long as we keep doing that, in most places, we're going to achieve herd immunity through vaccination probably by the summer. And we'll get on top of these things against these variants. But in the meantime, I think it's still worth being cautious, especially around kids for that reason. And so I think hopefully, kind of explaining how I'm rationalizing it and how we're dealing with it with our young kids, hopefully it gives a little bit of a practical example of, how I think it's probably good to kind of deal with these situations. But if you have a follow-up or additional questions, please let me know. It's hard. That's one of the more challenging things, I think, right now. I was really hoping that by now we would already be seeing community rates of spread low enough that I could feel like I could take my daughter to the volleyball tournament. But yeah, no, not such a situation yet. What other questions? Yeah, Jill.
I apologize because sounds like maybe you covered this last time and I wasn't there, but I know this is a frequent question but I keep hearing different answers. If you're fully vaccinated, can you be with anyone without a mask only if they're fully vaccinated? Even if they're outside your home. So if we have friends and so forth that are fully vaccinated, can we get together?
Yes. Yeah. So if you're fully vaccinated and they're fully vaccinated, you should feel very comfortable behaving as normal in an enclosed, in an enclosed setting. If you're in your home or whatever, you should probably be more careful of going out to eat in a public place that's not outside, going to eat in a restaurant. You could feel comfortable yourself with not likely to getting sick, but personally, I think it's still the responsible thing to do to try to avoid those circumstances where you can, and spend your time with vaccinated people in controlled environments where you can be just together with yourselves. And if you are, then yeah, absolutely. I mean, my family, my brother-in-law is the last one. He's going to get vaccinated. I think he got his first dose last week. In a few weeks, he'll, in like 6 weeks, I guess, he'll be totally done. And they're planning on coming for a long visit in July. My whole family, my parents, my brother and sister-in-law, all their kids. And, we're going to mostly stay home, but yeah, we're not wearing masks. We're going to be all together the whole time. I think that's absolutely fine. But you do have to be a little bit, then it becomes more difficult when you start talking about specific situations. Sometimes that's where it can be helpful. Like, okay, my 80-year-old parents are vaccinated, but there's like one 40-year-old who's not, and we all want to get together. Like, what should we do? I mean, at that point, it's like, well, the 40-year-old can make their own decision. If they really feel like they don't want to be vaccinated, and everyone else is vaccinated, the risk to that one person is quite low. And you're not really worried that 40-year-old is going to cause a severe infection in your 80-year-old or the other 40 or 50-year-olds. They could get some minor infection, but not severe. So, in that situation, I would say, well, if it's a 40-year-old who's really bearing the risk at that point, if they've decided not to be vaccinated, then I think it's reasonable to not exclude them. I mean, I think to this point, where I stand on the kind of social aspect of this is that some of those 40-year-olds have yet to even have the opportunity to get vaccinated, right? And so if they want to be, but they can't be, and then we're having events that like kind of exclude them or whatever, then it feels kind of wrong, right? But I feel like by May or June, everyone who wants to be vaccinated is going to at least have an opportunity to do so. So then I feel a lot better about sort of saying, okay, we're going to have this church event, and I'm not going to ask to see everyone's vaccination card at the door to verify that we're all vaccinated. Like, those who want to be are and have been or could. And unless somebody, reasonably says, I have an immunosuppressive condition, I've been vaccinated, but it might not be that effective, there's going to be special circumstances. But in general, I would say, at that point, you can hold events with reasonable measures without, masks and severe distancing and all of that. I think by the summer, we're going to get to points where even you can have gatherings where you don't know of everyone's vaccination status that are relatively enclosed, and feel comfortable that that's just, it's okay, and that it's at those people's risk who are not vaccinated. That's their decision. Do you have any follow-up, Jill? You want to ask something else?
No, that you answered my question perfectly. Thank you.
Yeah, great. Okay.
Did you see the question in the chat?
Yeah, have vaccinations been approved for teens? So the lowest that vaccinations have been approved for so far is 16. So the Pfizer vaccine is approved down to 16, the Moderna vaccine to 18. The studies that have been done or actively being done right now go down to 12. So there's currently studies both by the Pfizer and Moderna groups that go from 12 to 16 or 18, depending. And we're told, in fact, I just heard that yesterday Pfizer is preparing their EUA materials for patients down to 12. So I believe that those studies are about done or completed, and they're finishing up their data collection and preparing their submissions to FDA. So what my guess is that for kids or teens down to about 12, My guess is that there will probably be a hearing in early May, if I had to guess, on those, at least for the Pfizer one. Moderna may be a little later, but the earliest one would be the Pfizer vaccine. And my guess would be early to mid-May. And so if approval happens then, by mid-May, I would expect that there will be vaccinations available to kids down to 12 by June. Now, I don't know how the rollout's going to go. I mean, if now we've got enough vaccine to vaccinate everybody down to 18, I would expect that, pretty quickly we would just say, like, okay, now it's down to 12 that you can sign up. So I would expect by June, July, but June, I think, is probably reasonable to guess that down to 12. And then once they've finished their studies down to 12, they're going to begin enrolling in patients and pediatrics down to very small numbers. So down to 2, I've heard down to 2 for some groups, some down to 6 months. So it's going to go to pretty much everybody. But then there's just starting those studies now. So then it's going to take another, 3-4 months of accrued data. Again, depending on how, and these studies get more difficult as, hopefully as case rates go down in the community, these studies become more difficult to complete, because you have to have a significant number of infections before the study can end. And so if people are getting infected at a rate of 1 to 10,000 as opposed to 1 to 200, then it takes much longer. So, and we know also that kids in those age range, it's harder to detect systematic or symptomatic disease. So I think those studies are going to take longer to do, especially this younger cohort, for the reasons that I just said. So I expect, and that's why I think most people are expecting, that it's going to take most of this year before those studies from wherever to 12 get completed. What other questions do you guys have?
Looks like Denny has a question in the chat.
Oh, sorry. Is there a time delay to receive first or second vaccine? So essentially, you just need to be clear of your symptomatic infection. So once you're clear of symptoms and you've completed your quarantine period, or your isolation period in this case, then you can be vaccinated after an active infection. So you don't have to wait very long. So it shouldn't delay the receipt of the vaccine for more than a week or two after, assuming that you have a normal course, don't end up having severe infection. If you have a relatively mild disease, then usually within a week or two you could get vaccination. Absolutely, it's recommended that you get vaccination in this situation. Like I alluded to, didn't really discuss in detail before, but symptomatic disease doesn't lead to, and I guess, with respect to that Brazil example, symptomatic disease doesn't lead to the same degree or depth of immune memory. I mean, this is what vaccines do, is that they are designed to elicit a broad amount and very strong immune response that even a strong symptomatic infection can't typically elucidate. So even if you've had symptomatic disease, you're still recommended to get vaccination. Now, the one thing that I'll say about that is that the studies have now shown that you may only really need a single vaccination. So for vaccines that require 2 doses, so I haven't talked about J&J, which only requires 1, but for the mRNA vaccines, which require 2, really probably you get the benefit of the second vaccine dose out of just the first, because you had that symptomatic infection. So that symptomatic infection kind of serves as the first vaccine dose, and then the first vaccine dose is really your second, infection. You get a boost from that. Now, that doesn't mean you should just get your 1 and be done. You should still get the 2 as recommended by the FDA. But what you can feel confident in is that the data seems to indicate that after your first dose, 2 weeks after your first dose, you would probably be as protected as someone who's had 2 vaccine doses. Okay, for those who've had infection, how long does immunity last? Yeah, we kind of talked about that a little bit. For those who've had infection, yeah, it's probably not as long We kind of say between like 3 months is pretty safe. So 90 days following initial infection, we've seen very low rates of reinfection. Usually the only people that get reinfected in the first 3 months are people who have, immune deficiencies and things where they're not likely to elicit as robust an immune response due to initial infection. Typically that first 3-month period, we almost see no reinfections. But after 3 months, it becomes more variable. So that's really, I would say, what scientists and clinicians tend to believe is the limit of really protective, high efficacy protective immunity following a natural infection is probably 3 months. But there's going to be people, then it just wanes over time. It goes from 90+% protective to lower, and so then it kind of just depends. Like, do you get a high exposure? Do you get a low exposure? What's your immune status? After that point, there's certainly people who could probably be exposed 6 or 9 months later and not get infected. It just kind of then depends on more of the situation specific details.
So we're sort of winding down on our time, I'm sad to say. Are there any other burning questions that we must get before Brian? Don't want to cut those off. Not seeing any. Brian, again, this has been so helpful, so incredibly helpful. Really appreciate your time and your wisdom.
No problem.
Really grateful.
Yeah, I'm really happy to do it. Like I said before, you guys are really fun to be around and talk to, so I enjoy it. No problem here.
Great.
Thank you so much.
You're
Yes.
welcome.
Well, Brian, would you be up for closing us with prayer?
Sure, I'd be happy to. Like we were talking
Great,
about,
thanks.
yeah, we were talking about before it started. In the Orthodox Church, it's still Lent for me. So I'll close with a Lenten, probably the most famous Orthodox Lenten prayer. And it's called St. Ephraim's Prayer. And it's very penitential prayer. So, O Lord and Master of my life, take from me the spirit of laziness, despair, lust of power, and idle talk, but give rather the spirit of chastity, humility, patience, and love to your servant. Yea, O Lord and King, grant for me to see my own transgressions and not to judge my brother, for you are blessed unto ages of ages. Amen. So have a blessed Paschal Easter season, all of you, and
Thank you.
be well, okay?
Things on the remainder of your Lent, and when Easter comes,
Happy Easter.
hope it's a wonderful celebration.
It sure will be. Thank you.
Right.